Yeah, I'll just put it on for you. I think the mic, I can speak loud enough. Dr. Vandana Nath, our cataract, cornea and low vision specialist from Raghudeep Eye Hospital, Ahmedabad. She will be talking to us about a very common problem that we all see and mostly ignore, but sometimes you can't just ignore it.
Good morning. Thank you, Dr. Vaishali, for including me in this course. The case of the ubiquitous incisional Descemet's detachment. All of us as cataract surgeons wish to have an absolutely clear, crystal clear cornea on day one. But philosophically speaking, life throws us some surprises. So let us discuss this case of a 67-year-old female with a grade 3 plus cataract. And the left eye was already done 3 weeks ago with a vivity toric. And now we are operating the second eye, which is the right eye. So naturally, with the second eye, also the patient has expectations that it will be as good as the first eye. So this is what the surgery has gone on uneventfully, and we are implanting the lens, and everything on table is absolutely the way it should be, the textbook kind. And we're removing the viscoelastic, and everything on table looks absolutely all right. So we are confident that things are absolutely fine. But the first post-op day, this is the picture. The whole of the temporal side near the incision, you can see the Descemet's folds, and nearly 1/3 to half of the cornea is edematous. The patient is very unhappy and the surgeon is shocked. What happened? So we do an AIOS2025 to find out that there is a wonderfully large Descemet's detachment at the incision site. But if you see the central cornea, the central cornea is still reasonably all right. It's 556. So the edema has not progressed to the center. But we wanted to find out what went wrong. So this is the laser emission that is happening. Luckily, we record all our surgeries. So we go back and find out what happened. And the rhexis is done, and this is the incision. But notice ahead of the internal incision, there's a small bubble-like thing, which we noticed on table also. And sometimes we do have these tiny little bubbles. So, and we always stain our incision. After doing the side port incisions, we injected the viscoelastic with the soft shell technique, the viscodispersive and the cohesive now. And now when opening, that bubble comes out very nicely, but yet surgeon is suspecting, and we are inserting the spatula to see if there's a large DD, but we couldn't find any. So we decided to wait for a couple of weeks. But unfortunately, after the couple of weeks, now the edema has progressed to the center. The patient is even more unhappy after 2 weeks and said, my blurring is increased. And this is the pachymetry. You can see that it's gone to more than 600, 667, the central pachymetry is. So now, again, we did the AIOS2025, and we have seen that the Descemet's has increased, the Descemet's detachment has increased. And then now we decided to do an air injection. And this is the way we use a 30 gauge cannula, just bend it. This is the way we do the air injection. And we go to the opposite side, but first the surgeon is now opening again the main incision to see if there's any fluid coming out of that incision, so that we just depress the incision a bit to see if the fluid is coming out, but nothing came out. And we go from the opposite side of the Descemet's detachment and inject air and fill the whole chamber with air so that we can reattach the detached Descemet's membrane. So with the entire air fill, the next day it's slightly better. Again, even the next day you must do an AIOS2025 scan. So it looks reasonably attached, and after 4 weeks, finally, the cornea cleared, the patient was happy. However, if you notice, there is a small linear scar at the main incision. So that is where the Descemet's was detached. And pachymetry, everything came back to normal. This is the second case of a 64-year-old female, a myope, and whom we are planning a lens X with a toric monofocal IOL. And irrigation aspiration is going on. we've not noticed anything abnormal. But at the end of it, we see that there is a curled up Descemet's detachment, and mostly this is from the side port incision with the instruments that this has happened. And if you notice that the Descemet always curls up like this on itself. So you take the superior part and the surgeon is trying to smoothen it out, but it's still hanging there. We are implanting the IOL, taking care that now no instrument touches that part. And then we'll remove the viscoelastic. While removing the viscoelastic, we take care that our instrument, our aspiration port is not anywhere near that detachment. So see, you can still see that the Descemet is curled up there and the surgeon is trying to hydro it into place. But these Descemet membranes are so elastic that they keep curling on themselves. So this is when we decided that we will do an air injection on table because this Descemet would not attach by itself. And we did a full air fill. And this is the next day with a very mild kind of, there are still Descemet folds as a mild edema. But the anterior segment OCT shows a reasonably attached Descemet membrane with a, still there was a pachymetry of more than 700. The edema was still there. But at 2 weeks post-op, this eye cleared up and you can see the toric IOL well in its place. The third case is a 72-year-old with a grade 2 and planned for a phaco with a toric monofocal lens. Again, the phaco went well, but the surgeon is struggling a bit with the IA. And the patient's eye is moving, so it's away from the field. The focus is not very clear. And at the end of the IA, we notice there's a huge detachment there, if you can see. And again, it is folded on itself. So we are trying to, again, bring it back in its place. But after the lens implantation, and notice here when we are doing the IA, the surgeon very rightly is keeping the aspiration port well away from the site of the Descemet's detachment. We did not do any air injection because we thought that at the end of the surgery we could reattach it with the hydro. So we didn't do an air injection, but this is post-op day 1. So any detachment that you see on table needs an air injection at that very moment. With a severe edema and a huge Descemet's detachment you can see, and the pachymetry is also more than 700. So this edema will not clear on its own. By post-op day 7, it has reduced a bit, but the detachment is still persistent and the edema has increased. So even if you leave a detached Descemet's membrane even for a couple of weeks, the corneal edema is going to go on increasing. So keeping in mind the pachymetry, the anterior segment OCT, we decided to do an air injection after 3 weeks. We did do a proper air injection and the Descemet did attach very well. And after 2 months, this cornea cleared. But because of the delay in the large Descemet's membrane reattachment, there's a scarred cornea. So remember, this course is all about a stitch in time, air bubble in time. And of course, we cannot tell you the importance of the posterior segment OCT as well when you follow up these patients. So any interventions that you're doing secondarily, always corroborate with your posterior segment OCT. So each and every movement in the eye needs attention. All the instruments going in the eye repeatedly coat the endothelial layer with a viscodispersive viscoelastic at all stages of your surgery. And early detection and high index of suspicion find out exactly where the detachment is. Tiny detachments we always see usually at our main incision or sometimes in the side put incisions which can be left alone. But when there's a huge detachment, always air bubble it and use your imaging techniques, and the treatment options are quite effective. This is actually what we call an auto DMEC that we are doing. Thank you.
Thank you, Dr. Vandana. Those cases were really eye-openers that, and like you said, during surgery, keep your eyes open and keep your mind open to the fact that you can also complicate. Don't be blind to that. And I think prompt imaging, what I learned was that if there is anything that you did not expect, do an imaging, be it the cornea, do an OCT, if there's something, inflammation, dilate, check, get the retina check, do a posterior segment OCT, vision is not appropriate, again, do a refraction or a biometry to see what's happening. So anything post-operative, you do not, it doesn't match with your expectation as a surgeon, we need to tackle it and investigate it. Any comments?
In our hands, we have always done air bubbles, not C3F8. Yeah. Yes, you can. Yes. Then C3F8 would be appropriate.
That was a great presentation, ma'am. Do you want to comment on the usage of anti-glaucoma Repatec eye drop in Descemet membrane detached? Because people have been using Repatec eye drops.
Ripatec eye drops is usually for the endothelial cells.
Okay.
In Descemet's detachment, I have not heard of people using Ripatec.
Okay. Okay.
It's for the viability of the endothelium,
Okay.
mostly. Early Fuchs
Okay,
dystrophy,
okay,
yeah.
yeah.
You can take the mic.
Sir, you can use that mic.
In the podium presentation yesterday, and the suggestion from these guys I learned is to do a trapezoidal incision, because most commonly the DD occurs in the main incision. So if you do external, say 2.2, but internal a little broader, which you can do controlled way in a lens sex or I mean flex way, but even manual, that will reduce the chance of DD occurring with the manipulation through that incision. So that was a great stuff.
I see Professor Dr. Rohit Shetty. Welcome, sir, to our course. Would you have any comment on this ripasudil in Descemet's detachment?
I think what Madam said is right. It more of helps to regenerate the cells. But the question which was asked to me is, ma'am said that there was a scar at the end of it. A lot of these challenges happens the scar. So there are 2-3 people who have asked me whether losartan works for this scar. The interesting thing is we have no idea. Losartan works very well in the anterior 200-250 micron scar, but deeper losartan, whether so, I told that person to try it out and let me know whether it's worked, because that I think is a challenge when you have this kind of scarring. No, we make it. It's like preparation of losartan. But till you don't get losartan, the question for this scar is the lymphatic rust penetrates into aqueous humor, and lymphatic rust has maybe 30-40% of the work of TGF-beta of losartan. So losartan is commercially available. So losartan use, instead of using losartan, you can seek the microvision called Sika, another company called Lifnia or whatever. So I think that is a worth trying at a very early stage when you have a endothelial, the kind of scar she mentioned.
Thank you. So I think that's something we all could think about.